Um,
Good morning, everyone. Welcome to another
yes,
WEHA
now I do.
Wednesday webinar. I just ask that you please put yourself on mute for now so that we don't get too much feedback. And we are here for our part 2 of hoarding. But before we get started, I just wanted to mention a couple of things. Next month, we will not be having a webinar because of how they would naturally fall. It's going to fall on the first day of our WEHA conference. So if you're not registered for that conference yet, make sure that you do go register. You can go to weha.net to register for the conference. We will also be sending out a know before you go so that you can get access to all of the fun things that are going to be happening, such as a brewery tour and a few other odds and ends that we have planned as well. So stay tuned for that. Check your emails from your WEHA VP. They should be sending that out. So, but I will turn it over to Carla again to do our part 2 of our hoarding series. Take it away, Carla.
Good morning, everyone. Welcome back. This morning, first, what I'm going to do is a quick overview of the things that we reviewed last time. Your basics, what is hoarding disorder, and the indicators. And then today we're going to go more into the tips and tools for intervention, and kind of what that would look like and how it is that we do this here at Catholic Charities. So now you're working with somebody with hoarding disorder, or you have a friend or a family member. Where do you go from here? So again, the indicators, and what we are going to review the indicators for hoarding disorder. The indicators is collecting and failing to discard large number of items that may seem useless to most people. That is what we normally think of when we're talking about hoarding disorder, is the stuff. But an indicator is that a room that is so cluttered, it prevents the activity what that room is designed for. So the kitchen isn't being used for cooking. The living room isn't being used for lounging and watching TV or socializing. Another indicator is that the person feels significant despair and stress from the clutter, and there's a sense of embarrassment due to the clutter. Again, those are the indicators for hoarding disorder. And then we move on from there is more of an understanding of how this starts. How does hoarding disorder start? When negative life events happen and we find healthy ways to cope, we use our support system. But people that are suffering from hoarding disorder have had negative life events on top of other existing issues, and things become overwhelming. The outlook is difficult to envision. A positive outlook is hard. And so what they do is only take care of immediate tasks. And basically what I call they survive. They're in survival mode. And they not just in survival mode, but they're in the mode of doing things that make them feel better. And many times that is acquiring things or having certain things near them. That is what makes them feel good, and that's how they survive. So, where are we now? I'm not sure if anyone had noticed. Almost 2 weeks ago now, I was on the news because of stigma and hoarding disorder. And I just want to take a moment to make note about it. There was the news, the incident with the children that were found in the street that had been abused. And on the news, there were numerous interviews with police department and police officers, and they kept mentioning the house was hoarded, and they kept bringing up hoarding on the news along with this case. It was a very sad case of child abuse, but the news came to do an interview with me and didn't get what they expected, because the case that they were dealing with wasn't hoarding disorder. It was a case of squalor due to different reasons. So that's why there's such an increase of stigma out there, because the knowledge of what hoarding disorder is not readily known. You would think professionals, police officers, nurses would know what hoarding disorder is, but they don't. And the word hoarding is misused a lot. So hopefully, again, with this presentation and the information everyone gets, we have the ability to recognize what is hoarding disorder, what is squalor. And then with that, we're able to help direct and guide people to treatment that need it for hoarding disorder. So I thought I'd put together a little bit more information and some numbers, because a lot of people like numbers. This is those who have come to us for treatment with hoarding disorder, how it breaks down to age. 50% of the people that come to us for treatment is over 65. But if you look at it, there is a significant amount of people who are not older adults, which again means that hoarding disorder isn't something that just happens. It is done collectively, usually throughout life. The beginning age of starting within the disorder is usually in the 20s. So imagine if you start that disorder in your 20s, then when you're in your 60s and older, you have a lot more stuff, but the disorder starts way before that. So we're looking at intervention. You happen upon a client or a family member or a friend, and you feel the need to intervene. And when you do come across, usually you're coming across the site that looks more like this. There's a lot of stuff. And then you're in panic mode about helping this person. But I do want to point out that this is very clear that there's hoarding disorder going on with these pictures. But in these pictures, this is hoarding disorder also. It starts way before the house is packed, or an office is packed, or your hallways are packed. It starts way before that. So when we're looking at intervention, it's so much easier to intervene when it is at this level compared to the other pictures when the home is completely packed of items. So I like to give another example of where you will, something that you'll see that is already the beginning of hoarding disorder. Because if we're looking at the indicators for hoarding disorder, again, there may be a lot of items that seem useless to most people. In this picture, you will notice that there's extra dishes, lots of dishes. And this is for just the one person. So the items are not useful to just one person. There's way too many items. And this room is cluttered to where this person is no longer sitting on this couch to use it as the living room. And this person doesn't have friends or family come over because they are embarrassed of the state of their apartment. So this picture has all the indicators for hoarding disorder also. So, which means that intervention would be needed for this person, the same as it would be needed for the person in the other pictures. So back to, we have discovered someone who is suffering from the disorder. And where do we go from here? So intervention is the same intervention as you would use for any kind of substance abuse issues. So because hoarding disorder is a coping mechanism, the same as substance abuse, we do use same interventions. We do recommend that there's a meeting in a neutral environment, but that meeting needs to include numerous people from family to friends, anyone who wants to discuss how they feel that this coping mechanism of hoarding is having a negative effect on that person's life. And they need to share that again in a neutral environment with that individual to open up light how this stuff is having a negative effect on not just that person, but their friends and their family, and how it is preventing them from socializing, and it's having an effect on their health and their finances. So during the intervention, most important is providing education on hoarding disorder. Most people who suffer from hoarding disorder don't know what hoarding disorder is. They don't understand it themselves, and I always repeat this. If professionals in this field of caring for individuals, social workers, nurses, therapists, psychologists don't know much about hoarding disorder, the person who has it don't know. So what you guys learn here, and what I learned, we need to share that. We need to share that with many people of what hoarding disorder is. Explaining the coping mechanisms, and that it is a trauma-based disorder. It is come out of normally negative life events or trauma. So having clear discussions with the individual on negative impacts is important. Always keep in mind that the person is going to, at some point, get defensive and come up with excuses of the reason behind it. But through intervention, you want to clearly discuss on how changing this disorder is going to have a positive impact on them and everyone. It helps to motivate them to change. And that's what intervention does. It's a tool for motivation. So you're going to discuss on how treatment benefits everyone. And then when you start, after you get through those discussions, it is important to give the person the tools and the resources if they decide to want to change. It helps to get things started, because what you don't want to do is get someone all hyped up and excited and then send them home and on their own. So writing out a plan together and delegating people's roles. We'll go a little bit more into roles in a minute. But what's always important with intervention is discussing also consequences. If they choose not to have treatment, or if they choose to go through the path with their hoarding disorder. So discussing everyone's roles. These are a couple roles that we have found really work, is having an enforcer and a supporter. Because we find that people with hoarding disorder usually have to have some type of motivation. It's usually not the positive motivation that keeps them going, but in the beginning, it's usually the more negative things. So it is the consequences, but there always is an enforcer to those consequences, at least in the beginning. But that enforcer should follow these simple rules, clarifying conditions that need to be met to avoid consequences. I come across many, you think of enforcers, landlords many times is an enforcer. And what they will do is tell their tenants that to clean up, and very simple, oh, just clean up and then everything will be okay. But they don't give them very specific directives. They don't clarify what needs to be cleaned and how. Also, again, what is important is that the enforcer builds a respectful relationship and don't take things personal. But that will go both for enforcer, supporter. People with hoarding disorder will try many different ways to redirect you off of your mission. Again, they're used to coping with life and the negative things that come to life and negative thoughts and feelings. They're used to coping with their stuff. And if you take away their stuff, they're going to feel very vulnerable. So it's not that they do it purposefully, but the fear in them, who doesn't want to be vulnerable, will then lash out. They will lash out at the enforcer, at supporters, at everyone in this process, just because they're finally having to process their emotions. So in the benefit of treatment, try not to take things personal. For the enforcer, making sure realistic timelines and tools are given for these individuals. So back to, if landlords are the enforcer, many times, again, my clients get letters that say, clean up your stuff. I need it all clean by next week. And we're dealing with an apartment with 2 bedrooms and a living room that is packed. And of course, we could take everything out, but it would all come back. So if somebody truly wants their tenant to stay with them, which I come across all the time, the landlords love their tenants, they just want them to clean up. I have many discussions about realistic timelines, but keeping people to those timelines is key. Making sure that you're following up, making sure that they are given tools and resources needed. So landlords who want somebody to get rid of stuff, and it's obviously a lot of garbage. People need somewhere to put that garbage. Many times in homes, there's like one bin, and that's not enough. So the tenant is waiting to throw out more stuff because the bin's full. So many times, if we ask landlords if they will order an extra dumpster, or if they're willing to take trips to the garbage, if the client does not have a vehicle and is not able to do those things, all that plays part to the success of the client's treatment. Again, it's not all about the stuff, but it's not all about the mental health either. You have to work on both things simultaneously for success. Something to note that is very important is that we're expressing concern to our clients, to our family, our friends, rather than telling them what to do. Because ultimately it is their decision if they want to change or not. We're not going to treat them like children and tell them that they have to clean up. If they don't clean up, they face those consequences. And we discuss this all the time in the office. We cannot want this more than our clients. Sometimes they need more motivation to want to change, but ultimately we can't want this more than they do. So, as I touched base on the last webinar, is client wellness factors, and how we find the best success is treating all these wellness factors: emotional health, physical, financial, social, environmental, safety. Now, when you're looking at treatment and intervention, you have to have a plan for all of these. Something that is difficult for families is they want to intervene. The client says, okay, they are ready, but then there's nothing set up in place to treat these wellness factors. They don't have any insurance and can't find a therapist, or there's no one available to help them figure out their finances. So we have many people who are ready for treatment and want to change, but because there are not these resources lined up and ready, they are kind of set up for failure. And that's not what you guys want. It's not what we want. So keep in mind, if you're going to do intervention, be ready to have treatment and resources ready for them, that person. And for intervention and treatment, and we're looking at the mental health part, there are 3 different therapy techniques that are used, and that are used by the professionals. So when you're looking at connecting somebody with mental health treatment, there are not a lot of therapists out there that say that they specialize in hoarding disorder. They don't need to. They just need to know these type of therapy techniques. And this is what's used with our clients. Now, finding a therapist that may specialize more in addictions, addiction treatment, or more in anxieties may be helpful, but ultimately every therapist is used or trained to use these therapy techniques. And we find that the CBT works in most cases with our clients, but all of us, when we're looking at intervention, will need to know what motivational enhancement is, because we need to keep these people motivated throughout the process of treatment. And sometimes that's motivation during the intervention period. So we need to know how to motivate your individual, what motivates them. And it is different for everyone, but you should be able to sit down and think, if it's your client or a family member, friend, what motivates them? Is it to be able to be social again and have friends and family over? Or is it the motivation to have some type of, let's see, I'm trying to think, if some type of surgery. So we have many clients that don't have surgery because after surgery, they have to go home to a clean house and a safe house. And it's not at that point, so they don't have surgery. So helping your person find that motivation is very important during your intervention steps. So last few things that I will go through is making sure to simplify the process. Hoarding disorder is overwhelming, not just to the person, but it's overwhelming to those of us who are helping with interventions and treatments. So for their benefit and for our benefit, simplify the process. Simplify the process of the home, the actual process in the home of clearing out, categorizing, cutting out stuff, containing stuff, but also simplifying the process of delegating the therapy part to a therapist, support to a specific person, simplifying finances to another person, making sure you are creating a team and not taking it all upon yourself, because you will burn out. You will burn out quickly, and then you won't be able to support that person as they need throughout their process. So I do need to note things that you do not want to do. When you're hitting roadblocks, please don't be argumentative. When you're frustrated, don't blame or shame the individual. Don't throw out items without permission. Back to making sure not to take things personal when they are being defensive. And don't expect their home to look like yours. That is setting someone up for failure also. People with hoarding disorder will always have a certain amount of clutter. They will never be back to the point of where you may think they should. They will be to the point where they are functioning and able to maintain a new routine. So I'm hoping that this additional information helps everyone out, again, in the process of working with individuals. But we do need to be realistic on all this, as I am. It's easy enough for me to tell you guys these things, but I am very aware that communities don't have all the resources. So it is everyone's job to get creative in finding the resources, but back to having the knowledge and of hoarding disorder and what it is, will help direct you on your mission to help others with the disorder. So, all that being said, let me see if we can now unshare. Let's see. There we go.
Thank you, Carla. Does
You're
anyone have
welcome.
any questions for her? You can feel free to either come off of mute or go ahead and put it into the chat box.
I have a question. So if an individual just does not want to engage or admit that, that they do need help, how do you kind of go about that?
First of all, I will say, when I've gone through the indicators with an individual, I have them tell me if they see those indicators. I have not had one person deny that they have the indicators. One part of intervention or treatment is somebody admitting they have a problem, right? So I've had plenty of people say that they see that they have the disorder, but they are not ready for change because those emotions and those traumas, they are not ready to deal with. It is up to them. I make very clear discussions about this, and I make sure to walk away from conversations knowing that they will be facing their consequences, but we are here when they are ready for change. Sometimes it is planting the seed of information and letting them go through it and come to you when they need help. It's always the best way is having them search and ask for help instead of enforcing help upon them. But that goes back to just motivational treatment. You gotta see what motivates them, but ultimately it is not illegal to have hoarding disorder or to live in a home that is hoarded up. And it is their decision, as the same as those with addictions. It is their decision. And unfortunately, some people do have to hit rock bottom before they're ready for change. But if you have given them those resources and they know who to contact and call when they're ready, that's best case scenario.
Thank you. And I see, Kendall, you've got a question?
Yeah, I mean, it's a little bit more of a story, I guess. I'm a social worker in Wauwatosa, so I am in the Milwaukee area, and I just had a really unfortunate situation happen last week with a client that I've been working with who we were pretty sure had hoarding disorder, but she had never let anyone into the home. And so I'd been working with her for the last, 6-8 months. And we were making very little progress with her, being willing to even let anyone see into the window, to see into the home. Unfortunately, last week she killed herself because police had forced their way into the home a couple days prior for a welfare check and discovered the condition that she was living in. And a couple days later, I think she knew like what was coming. Now that there was proof of what was really, really significant hoarding, probably like 7-foot floor to ceiling, just garbage essentially everywhere. Couldn't even walk through the home. She was found at the top of the stairs with she had hung herself and had been found on a pile of garbage essentially the next time someone requested a welfare check. And it just really hit home to me because I had been trying so hard to just, get her to open up. And we had talked about, different things to address what was going on. And she, would have days where she seemed more open to it, and then other days where she was just overwhelmed and would say, nope, 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 I'm not doing this. But unfortunately, yeah, police did a welfare check. She didn't answer the door. They went in and found the situation, and she had told me many, many times, if anyone ever forced their way into her house, she would kill herself. And that's exactly what happened. So it's really, really unfortunate that it came to that. I don't know like what else we could have done differently. I felt like, neighbors were calling and complaining about smells and different things. And she had actually had bed bugs that were getting into other condo units near her. And it was this whole big thing, just like a really unfortunate situation. But again, I have to kind of remind myself that like we tried hard to get her to open up to us and get help, and she made the decision not to. And unfortunately, this is what came of that.
Yeah, that is unfortunate truths behind hoarding disorder. I've worked with the show a few times, and they had told me that there have been numerous people who were on the show that ended up committing suicide.
Wow.
So the quick clear outs again is not best approach for people.
Right.
So
Well, and unfortunately in this situation, like once we learned that there was this bed bug situation, the health department was like, we have to address this. Like it's getting into other units. We can't just treat these units on the other sides of her. Like it's coming from her unit. And, so that was where I was trying to build rapport with her to say, like, we just need to get this taken care of. I mean, knowing in my head that was going to mean decluttering, because of course we couldn't treat the apartment with a bed bug remedy without getting some of that clutter out of there. So that was where it was really hard, and where we had to keep pushing her, because the neighbors, were dealing with this basically a human health hazard. And so that's why we had to keep pushing her to say, like, we have to get these bed bugs treated. But I know she knew that as soon as somebody came in to treat it, it was going to open up a whole bigger can of worms. And unfortunately, that's exactly what happened. So
yeah, that and just think, whatever traumas and emotions that she has built up and kept bottled up for so many years behind her coping mechanism.
yeah.
The thought of having to expose all of that,
Yep.
she would have rather have lost her life than have to deal with that type of pain. And that's exactly the type of people that we're working with. And that's why it's so important to make note of their mental health. There are numerous people that do come to our program and say they want help, but we notice that they are not mentally stable enough for treatment. And so we do not work with individuals if they're not stable enough. For this fact is, again, it is not about the stuff.
Mm-hmm. Thanks.
Can I ask, in those cases where you have noticed that there is maybe the unstable mental aspect, are you able to refer them elsewhere, more so for that mental health?
It all depends, on the situation. But there's individuals that we've referred to crisis lines through the Department on Aging, for other services. And sometimes it's a matter of us getting contacts of family members to see if the family member will help that person navigate getting set up with a mental health provider. Lots of times the individuals have paranoias and fears of doctors and treatments and medications. So sometimes it's a matter of us working slowly, just again, building that rapport. Just like she said, the whole thing with this is that it's not, right now we're dealing with people who have had hoarding disorder for so many years. But I will tell you, I have so many people who are calling for help with their disorder, and it's not at that max. And even though we are going to have those cases where they are at the max and they've gone under the radar, the more that we can, notice this disorder and take down the stigma in earlier stages and people get treatment quicker, then it will be easier on all of us as professionals that are dealing with these crisis situations down the road. Yesterday, I was talking to a doctor, an OBGYN, and we were having a discussion about postpartum depression. And she was in agreement that it is the same thing as hoarding disorder. These people have gone through, you have a baby, it's traumatic. You end up having physical health changes and changes in your environment and finances and all this stuff that comes up. And a lot of mothers then start to cope by surviving, leaving stuff unkept, surviving, just taking care of that baby, but by just being able to focus on that and not focusing on laundry and dishes, things start to build up and pile up. It is the exact same coping mechanism that's being used within the postpartum depression also.
That's very interesting. We do have two other questions. It looks like Carlene, I'll let you go first.
Hi, thank you. So my name is Carlene. I'm a social worker with the La Crosse County Health Department. So I work a lot. I work very closely with our sanitarians. So once they come across our desk, they've been reported by someone, whether it's self-report, the pizza delivery person, the landlord, what have you, EMS, if there's been emergencies. So when we respond, we are going out when it could be condemned. So that's kind of the aspect that I'm coming from. I just want to pause really quick though and just say, Kendall, I'm so sorry for the loss of your client. I know that that's incredibly difficult. Not firsthand. I have had coworkers who have lost a client from suicide. So I hope that you have some help as preventatives for yourself, that you're doing some self-care, that you're maybe staffing that with some internal supports that you have, clinical supports, whatever you need to address that yourself.
Thank you.
Absolutely. It is definitely not easy. When I go out, we are typically asking, who knows about this, because it is such a private, embarrassing thing for them. So I was actually just at a house call yesterday where someone had fallen and was on the floor for 3 days before they were able to army crawl to a phone to call for help, and called the one person that they trusted. So, with that, it's like, who knows, and how can we go forward with this? We do utilize our crisis line. I have had people say, if you condemn my home, I'm going to burn it down. So, there definitely is that risk factor. And is it said for shock value? Is it said for, actual intent and purpose? So I can't make that call. Definitely make that phone call to your local crisis line. Encourage them to use 988. It's a free service 24/7. Whether or not your local county has a crisis line, that's something to consider and look into. They may need to be hospitalized, and what are the resources? Like Carla was saying, there really are not a lot of resources. And, fortunately, you have a team of people that can kind of go at it from, the clinical perspective, the one-on-one, the case management, how your program operates. I wish that we could get something like that. But you just have to call on natural supports. Do they have neighbors? Do they have friends? Do they have family? Who can support? Who does know, like I said, who do you trust to come in? Do they qualify for any services through like the ADRC or anything? We're blessed to have a contract with our with our local landfill so we can do an application, and it's a free service. They actually budget for that annually to pull up a dumpster and dispose of, you know, a given amount of, say, $250 for a given household. And that's a lot of garbage. I am finding it's a lot easier for people to purge the filth and squalor, so the garbage that they have in their home, than those items. So it's not an easy thing. And I am new kid on the block compared to you, Carla. I just wanted to share a little bit of what I have learned in the 1.5 years that I've been doing this. But there definitely is a lack of support, and I appreciate these conversations because it just kind of reminds you of some things or gives you new tips and tricks, because people are in denial, people are embarrassed. You know, and for the individual that I met yesterday, literally no one knew that it looked like that because it's a beautiful neighborhood, it's a beautiful home. They just don't let anyone in, and you would never suspect. There's not the red flags of things standing up in the windows. You know, it's more further back in the home and lower than the window level of the exposed areas of the outside of the home. So I'll quit talking because I know we're limited on time, but I just wanted to share that and again express my sympathy for Kendall. So thank you for doing this.
You're welcome.
Thank you for sharing. We'll go with Carrie.
So I also work in public health, and oftentimes when we get these cases, we're not at the beginning stages. Like you showed that picture of, you know, the couple things that were sitting on the couch. We're talking about like extreme cases, usually once we get involved. And oftentimes there's animal hoarding, there's animal feces. I mean, it is a human health hazard, and public health, you know, we need to step in and, you know, we could placard this home or apartment. Oftentimes, you know, it's an apartment and it's affecting other units, kind of like the other two speakers had mentioned. You know, and according to one of our caseworkers, she tried getting help with Catholic Charities, and she said there's a year-long waiting list, which I completely, I understand. But there's often people that don't have any help at all. They have no friends, they have no family. You know, they can't possibly do this work by themselves. And the most recent situation I had, it was actually not hoarding. I think it was the Diogenes syndrome. It was pure garbage. She wasn't embarrassed about it. She let us right in the home. But she has no one to help her at all. And situations like that, I don't even know how to get those cases resolved.
I've had a couple of clients with Diogenes and have worked more with the health departments, and unfortunately having to go connect the health department, Department on Aging, and court system, taking it in front of judges of making sure going into the homes if the person wasn't letting us or wasn't complying with what they needed to do. I'm not as worried with people with Diogenes of making sure that they comply with the different things from the city of clear outs and having the city come and actual clearing out if they're not meeting those, you know, the citations that they have, because the Diogenes again is a different type of a dementia than the hoarding disorder as the coping. So people with the coping mechanism, and they're faced with clear outs and those higher levels of pressure, then may, you know, turn towards suicide. Where if you're working with someone who when it's not their coping mechanism, but more of a dementia issue, it's less likely then you're going to run into those type of situations of someone who is, you know, threatening that they're going to, you know, kill themselves or burn their home down, or so be it, just because of the dementia is a different factor. And then that's why then we get involved with the Department on Aging and then really doing more education on the Diogenes syndrome than that it's hoarding. So again, it goes back to, unfortunately, my base has been education for so long, because there's so many entities that need to be educated on hoarding disorder and Diogenes. But I feel for all of you that have to work with these crisis situations, because even if the individual is taken out and placed, hospitalized for some type of treatment, they're released back to their home, and then it's just another cycle. So there needs to be more advocacy on treatment for hoarding disorder, and we are blessed with United Way here in Milwaukee and Waukesha County. And that's how we're able to do our program between Catholic Stewardship Appeal and United Way. So I'm so grateful for United Way. And I try to since I talk to people from across the country every day. Today, it was Vermont and California on the line before I even spoke to you guys. And I talked to them about getting their local United Ways at least online. So if we can start getting more states involved, and then hopefully little by little we'll make more progress in treatment and payments for treatment, because it all does come down to funding.
Yes, thank you for that. And I did see that Carlene put another little tidbit in the chat as well about sometimes if things are not progressing the way that it should, kind of switching gears and trying up some other tactics as well. So thank you for that. I do know we are almost a half an hour over our scheduled time. I didn't want to cut it too short because it sounded like this was a great discussion and people did have some great things to add to the conversation. So I didn't want to cut it off too soon. Carla, thank you again for joining us. It has been wonderful. And we would love to be able to have you again in the future if time allows for you. One last thing I just wanted to share is for WEHA, our Northwest and our Southeast VP positions, as well as a director position, is open. Technically, the deadline was yesterday, but if you would like to have some interest in becoming a VP, I am going to type Sarah Ward's email into the chat. Just send her an email showing your interest. So since yesterday was the deadline, if you are wanting to reach out to her, please do so today, because of how our bylaws are written. It does need to be at least 30 days before our business meeting, which will be taking place next month at our conference. So please, please, please reach out to Sarah if you are wanting to become one of our VPs. We would love to have you. So I did just pop Sarah Ward's email into the chat box. So please join us again next month. We are skipping because of the WEHA conference, but we will be back in October with a new fresh topic, and we will be sending out that announcement. So please stay tuned for that. Thank you guys. Take care. Thank you again, Carla.